Hello and welcome, everyone. This is Caroline Fichtenberg speaking. We are so glad to see so many people on the line for this webinar today. We're going to be talking to you about a report that we just released on community resource referral platforms and hearing from two organizations that have been implementing one of these platforms, and we'll be learning about their lessons learned and their experiences with that. Before getting too far in, wanted to introduce myself and Siren to those of you who don't know us. So I'm Caroline Fichtenberg. I'm the Managing Director of Siren, which is the Social Interventions Research and Evaluation Network. Siren's mission is to catalyze and disseminate high-quality research that advances healthcare sector efforts to improve health equity by addressing social risks. We do three main things. We catalyze and conduct high-quality research. We collect and disseminate research findings. And we provide evaluation, research, and analytics consultation services. At the bottom of the slide, you can see the link to our website, as well as our email address and our Twitter handle. For those of you who are not familiar with us, I would highly encourage you at some point to go and view our evidence library, which is on our website. This is where we have compiled, at this point, over 700 different resources, articles, reports, issue briefs that talk about or provide information about the effectiveness of healthcare sector interventions to address social risks. The website where you can find this evidence library is listed at the bottom of this slide. So before we go further in this presentation, I just want to let you know that we are going to be taking questions from on these presentations through the chat function, which is on the lower left side of your screen. So any questions that you have at any point during this webinar, please chat them in, and we will respond to them at the end. If you have technical issues, also please use the chat function, and someone from ReadyTalk is on the line and was able to answer any technical questions that you have. And the webinar is being recorded. The recording and slides will be made available in the coming days on the Siren website. So we're going to be talking today about a report that we just released 2 days ago about community resource referral platforms. We've intended this to be a guide for healthcare organizations about both what the landscape of these platforms are and also about the experiences of early adopters of these platforms. We want to thank our funders, the three organizations that are listed on this slide, the Episcopal Health Foundation, the Methodist Healthcare Ministries of South Texas, and the St. David's Foundation, both for their financial support for this work as well as for the substantive support and help that they provided all along the way. I do want to highlight that since we first released the guide on Tuesday, we have made a few minor edits to it, specifically in relation to the functionalities of two platforms, Healthify and Unite Us. And so if you downloaded the report on Tuesday, you probably want to go back and download it again. We uploaded a new version yesterday, I would say around 8 a.m. Pacific time. So I want to now introduce our speakers today. I'm going to be the moderator for today, but the folks that you're really going to be hearing from first are Xiao-Chi Sim, who is the Vice President of Applied Research at the Episcopal Health Foundation and really was the person who helped plant the seed for this idea and helped make it all happen. Next, we're going to hear from Yuri Cartier, who's a research associate with Siren and who is the lead author of the report, and she's going to be walking you through the main findings. And then we're going to hear from Pat Schoeneman, who's the director at the Brazos Health Resource Center at the St. Joseph Regional Health Center in Texas, and from Kristen Scholl, who's the VP of Population Health at the Alliance for Better Health, and her colleague Lori Peterson, who's the Senior IT Business Analyst at the Alliance for Better Health. Before going further, I want to start out by sharing or asking you to respond to some questions. We would love to know who you are on the line. So if you could please fill out this poll and tell us what kind of organization you work for. Which one of these fits you best? We realize that some of you probably work at organizations that don't quite fit there. Pick the one that fits best, or just click other if really none of these really apply to you. And we'll give you a few seconds to fill that out, and then we'll share the results with everybody. And as folks are filling this out, I want to remind anybody who's joined a little bit late, we are recording this webinar, and the slides and the webinar will be posted on the Siren website after the webinar, likely the end of this week or early next week. We are also asking you to chat in any questions that you have at any point into the chat function, which is on the lower left-hand side of your slide. And we will be responding to questions at the end of all of the presentations. Great. A good number of you have filled out the poll, and so we're going to look at the results. Interesting. So most people, looks like a quarter of you guys didn't fit into any of these categories. And then the next biggest group are folks who are calling in from safety net healthcare organizations. And we have a number also of non-safety net healthcare organizations. And then a smattering of other folks from other kinds of organizations. That's great. Thank you all for being on the line. Before handing it over to Yuri, I want to just say out loud a disclaimer, which is that this webinar and the report neither of those constitute a product endorsement or recommendation by the University of California, San Francisco, Siren, Episcopal Health Foundation, Methodist Healthcare Ministries of South Texas, or the St. David's Foundation about any of the products that are in this guide. I am now going to hand it over to Xiaoqi to give a few introductory remarks about our report and this work. Xiaoqi, handing it over to you.
Great. Thank you so much, Caroline. On behalf of all three funders in Texas, Episcopal Health Foundation, Methodist Healthcare Ministries of South Texas, and St. David Foundations, we also wanted to extend our welcome to many of you to this webinar. This has been, a very important project, from our perspective, in the sense that, we knew that this is a rapidly emerging market of technology-based platforms, and we felt like there's really lack of a synthesis or systematic compilation of data and information regarding all these various platforms. So we are very happy, to join Caroline and her team, as well as others, for this great, 1 hour conversation about, how this research or how this report, really, is able to offer some very practical applied insights, as well as considerations for any community organizations or healthcare providers before they make a decision on implementing any of the community referral platform. We look forward to these conversations. And I would like now, to maybe pass it back to Yuri or Caroline.
Great. Thank you so much, Xiaoqi. We are now going to pass it over to Yuri to talk to you more about the report.
Great. And thanks for joining us. It's exciting to finally be able to share our guide on community resource referral platforms, which, as Caroline said, was released 2 days ago, and since it clocks in at a breezy 98 pages, I imagine you've all read it already. Just kidding. We wanted to share some high-level findings from the guide so you can get a flavor for what we did, what we learned, and what we still don't know. I'd like to start actually by asking you another question. Is your organization in the process of implementing a community resource referral platform? Yes, we're currently using a platform. No, but we may in the future, or not applicable to our organization. And I'm just going to, wow, you guys respond really fast. I will give it maybe 3 or 4 more seconds, but we've got a ton of responses already. All right, let's see what's come in. So it looks like most of you are considering using a platform in the future, but actually a pretty even spread across different categories. This is super interesting. Thank you for answering. So Xiaoqi gave us a great overview of why we decided to work together. There are a number of technologies out there that are designed to help healthcare organizations streamline the process of referring patients to community resources to help address their unmet needs. And safety net healthcare organizations and healthcare organizations in general could really benefit from guidance about these platforms, what they are, how to select one, how to implement it, and so on. So to accomplish this goal, we engaged in two main activities: reviewing up to 10 of the most widely used platforms to learn about their functionalities and features, and talking to users to understand their experiences. Before going any further, it's so important to share that one of the biggest challenges we faced in conducting this project is that this area really is a moving target. Companies are changing their products regularly, new companies are popping up. The sector is still very new and still changing, and that means that what is in the report is definitely a snapshot in time. So we identified these 9 platforms through web searches and word of mouth, and limited the search to platforms that included the 2 key functionalities we were interested in: a searchable community resource directory and technology to facilitate referral management. The platforms also had to serve healthcare clients, although it didn't have to be exclusively, and the platform had to be available to be implemented in Texas. If a platform met our inclusion criteria, we reviewed its features through a functionality questionnaire, a virtual demo, and a call to discuss anything that was unclear. So as you see, the 9 platforms that we included here are Aunt Bertha, Charity Tracker, CrossTX, Healthify, NowPow, One Degree, Pieces Iris, Tab Health, and Unite Us. And there were others we found out about along the way that we list in our guide. So as we said, the 2 key functionalities we were looking for were a resource directory, so something that was searchable, regularly updated list of organizations and agencies that provided services to help address patients' social needs, and a referral management system, which we define as the ability to send referrals to community organizations and track referral outcomes, i.e. close the loop, to get information through the platform. And that's important about what happened with that referral. Other functionalities and characteristics included privacy protection, so compliance with HIPAA and other privacy regulations to protect PHI or PII, and measures to ensure data security. Systems integration, which encompasses 2 aspects: the ability to transfer data between, say, an EHR and the platform, and the ability to seamlessly move from the platform and EHR vice versa. Social risk screening, so the capacity to record patients' responses to a questionnaire and identify social needs. Care coordination and longitudinal needs and care tracking, the ability to define care goals, see referrals, services, and other activities over time. Reporting and analytics, the capacity to analyze social needs screening and referral activities and outcomes, and vendor responsiveness and capacity, which was really important when our informants were deciding which platform to invest in. And we defined that as the vendor's willingness and ability to tailor the product to users' needs, as well as the perceived capacity of the vendor to provide the level of product and implementation support. And one last factor was cost, which varied a lot between products and between customers. In our guide, we have a side-by-side comparison table that shows the current features and functionalities of the 9 products we reviewed, and product profiles in the back of the guide if you want to learn more. This is all coming from the vendors, and this space is, again, moving super quickly, so make sure to check with them for updates. And I want to add that functionality-wise, these products are becoming more and more similar, so going forward, the main differentiator will probably be in implementation support, and that's why we're focusing today on implementation experiences, because we think that no matter what platform you choose, the experiences and challenges will be similar. So I'm going to turn now to what we heard from these early adopters. We interviewed people from 39 organizations who we identified through word of mouth, vendors, and good old-fashioned Googling. We attempted to interview at least 2 organizations per platform and get a good geographical spread. Our informants were mostly decision makers, not frontline staff users for the most part. So you can see among the 9, 4 were social service organizations. That's the dark blue. And we had a good, the largest group was health systems or hospitals, which you can see in kind of the medium blue there. Good representation from community health centers in turquoise. We had 10 informants there and a few other types of organizations. And I want to mention briefly, we also had pretty equal representation from across the country. And for the most part, our informants were in their first couple of years of platform implementation or were in the process of doing or completing a pilot. Only 4 were in the decision-making phase when we spoke to them. All right, now let's get on to the good stuff. So if there was one thing we heard loud and clear from our interviewees, it was that implementation was taking longer than they thought, especially when it came to engaging social service organizations in the community so that they could achieve closed-loop referrals. On the technical side, EHR integration and addressing privacy concerns were the main challenges. So here's the advice we heard from informants to address the challenges they encountered. The first is to engage community partners from the beginning. As one informant said, before you start, make sure your community partner is actually willing to be a recipient of that type of referral. If they're invited to the table early on, it helps them understand what's being asked of them. Engage your partners early on and ask them what their concerns are before telling them what you want to do. Secondly, examine what already exists in the community so you can avoid duplication and proliferation of redundant platforms. If the ultimate goal is to create a more coordinated healthcare and social services delivery system, we want to avoid a world where we're asking social service organizations to log into 5 different platforms, as one informant said, and that's starting to already happen in certain parts of the country. The informant told us, if I were to do this all over again, I think I would bring key stakeholders from all hospitals across the state to the table with our community stakeholders, and together figure out what would collectively be the best platform. Go slow to go fast so that everyone's using the same thing. Another recommendation is to have a clear understanding of your goals and needs. Consider the kinds of assistance that will help patients the most. What staff will be needed to provide that assistance, the information system requirements to support the care team, and the external partners necessary for the system to work. As one informant said, the health centers that have really thought about their care model and who on the care team is allocated to be addressing social and economic factors have a better time adopting the tool because they've thought through some of the larger system and workforce issues. And a couple last recommendations I want to share. Don't assume that if you build it, they will use it. Our informants suggested involving staff in clarifying your goals and needs and identifying champions who will lead end users through what will likely be a bumpy implementation process. And the last recommendation is to evaluate the impact. Right now, we know very little about the impact of implementing one of these platforms. Impacts of platforms might be on patient health, patient and provider satisfaction with care, or healthcare costs. And of course, our team at Siren would strongly encourage everyone conducting evaluations to please share results of your evaluations publicly so that the sector can collectively learn from these experiences. I want to close by saying that while we were gathering information about these platforms, we discovered a lot of different approaches we didn't have time or scope to cover in detail, but they're important to keep an eye on, and our full guide links out to more information about these if you're interested. First of all, EHR vendors are moving into this space, not only building social risk screening modules, but actually launching referral portals for community-based organizations. Second, community information exchanges, like the one developed in San Diego, are also gaining a lot of momentum as a collaboration infrastructure. We additionally wanted to mention the Pathways Hub model as an intervention approach that combines medical, behavioral, and social care supported by technology. And lastly, but maybe most importantly, let's think about how the landscape will look 4 or 5 years from now, and let's design interoperable systems
that are truly at the service of vulnerable members of our communities and the people who are working day in and day out to support them. And with that, I want to thank you for your attention, and I'd like to now turn it over to our first guest presenter. Pat Schoeneman is the director of the Brazos Health Resource Center, part of CHI St. Joseph Regional Health Center in Texas. Over to you, Pat.
Thank you so much, Yuri. Okay, so I'm speaking to you from Bryan, Texas, where CHI St. Joseph Regional Health Center is located. They are my employer, and at this point they are supporting the Health Resource Center in its efforts to be a hub for community resource information. In our community, we're part of the statewide 211 Information and Referral Network. But just to let you know what we do as a health resource center, we're local. We're here for our county, which is Brazos County. We coordinate, communicate, and assess situations for residents in need. We provide information, referral, sometimes application assistance, sometimes material assistance to help meet those needs, and sometimes we coordinate material assistance between different organizations. We can offer a meeting place for agencies that are either headquartered outside the county or even within the county if they need a place to hold appointments or meetings with their residents. We have and we will continue to host educational sessions. Where we are located is in the hub of other community resource agencies in our center, and we are a community resource coordination group participant. We are not at this point the facilitator for Brazos County. There is another organization that holds that role. So we just want to be available to people to we are always in the position of trying to learn more about community resources and possibilities for those in need. Sometimes we have had to make it up as we go along, but we always try to do it together so that both the participant who needs the assistance and our organization are learning more about our community and ways to overcome some of the barriers. So just in a nutshell, we are at the center of a number of organizations who are members with our network, who are across sectors, not just healthcare providers, but other connected community agencies and organizations, faith-based pantries, helping organizations, other network coalitions, and then some healthcare groups as well. Here's where we are, over here on the east side of the state. This is a fairly significant geographical region that encompasses 7 counties called the Brazos Valley. Brazos County is right here in the center of all of this, and we make our network available to the resource organizations in all 7 counties. So we are the administrators for this resource network. Our network under Charity Tracker is called Brazos Valley Charity Tracker Network. There are other Charity Tracker networks in Texas, and as I understand it, well over 1,000 in the United States. We are the administrator. We have some local control over the design and process of our network, and we use it as our primary data collection center. So when we launched the Charity Tracker network, we did some things that are very different. We preloaded the service information on all of the organizations in our 7-county Brazos Valley area as long as it was published or produced by the organization itself. We collected lots and lots of information at many, many community network meetings in order to fill the network with that information. The second thing was the organization itself, CHI St. Joseph, subsidized the cost of the network, and so we were able to provide membership to those joining at no cost to them. We also, as part of designing this under a health network, had it pass under legal review in the CHI system so that it would be HIPAA compliant. And part of that was requiring that any client record entered into the system had to had to have a release of information signed by a member of the head of the household in order for that record to be entered into the system. And the system itself allows us to do that either by paper and have it be uploaded, or by having the client sign electronically on a touchscreen or using a mouse. Both a client and an agency representative who is a member of the network have to sign that document. We also agreed to minimize the personal detail in a client record in order to maintain HIPAA compliance. So there's not diagnosis information and there's not other detail in the assistance given, because it's crossing sectors in the resource availability and the resource members in our area. And then as the network administrator, we are continuously updating the information on the services and the agency information in our area as it becomes available. We, as the agency administrator, invite as many organizations as wish to join our network as want to join as possible. We provide demonstrations. We have an in-house expert who has the ability to solve issues, answer questions, amend the network, customize fields, correct errors. It's really lovely to be able to do this where we are, and to custom add things like categories of assistance or particular pieces of demographics just within our own network to make it as workable as possible for our members. For instance, we were able to work with the software company Simon Solutions to create a group function that enables a group to hold the data for the clients that they share amongst their group just to their group. And so that enabled us to start a home repair coalition and provide some project data management that was secure for that group. Also, we created and published a user guide, which we hand to every agent who joins the network at each organization so that they have a hands-on way to go back through and answer their own questions about how our network works. And I have to give a lot of credit to my office manager, Shondell Blakemore, who wrote that book. She did an outstanding job creating what I call Charity Tracker for Dummies, and put it together so that that was available, that we could offer to every user who we give a demonstration who joins the network. One of the features that enhances our ability to talk to each other and try to meet some of these undefined needs for which there is no resource is the ability to post a bulletin. These bulletins are part of the home screen when a user logs in, and there is the capability to both post the need and then answer the need very, very simply with a bulletin response. One of the features that we like about this is that users do not have to be logged into the network in order to receive a bulletin that is posted. Everyone who is a member of the network has their email address in the system, and they receive an email notifying them that a bulletin has been posted. But likewise, the responses are also on the same universal email distribution. The network itself allows us to turn on or turn off that feature so that we can just post bulletins to the home page, or you can elect as a user to continue to have all those emails sent out. We do admonish all of our users to be careful with the number of responses or to reach directly out to the individual who posts the bulletin. All of the contact information for the agents is contained in the network, and so that is also a possibility. So one of the examples of our use of the network that enabled us to do something which was really extraordinary, one of the case managers in the hospital had a situation with a patient who needed to be discharged but had no place to go. And so Health Resource Center was contacted to intervene and to try to figure out what to do for this patient who was going to get her treatment at the hospital but had no place to stay. So we were able to call on our members, find the type of support that she needed, including 6 weeks of a place to stay at our local Bridge Community Shelter, find a way to transport her on a daily basis to get her treatment. Our local public transportation system runs 5 days a week, and so we had to do something about the weekend transportation, which a local church was able to pitch in on and cover the cost for that. So we had the portion of the rent at the shelter paid for, which they offered meals, and so her room and board was covered. Her transportation was covered by churches, and then some prescription medication assistance was provided as well. And we were successful in getting this lady to complete her treatment under this circumstance, which was kind of extraordinary, for a very, very modest cost using our Charity Tracker member network. So what are some of the barriers that we encountered as part of this process? Well, even when you offer a free resource to people, there is some hesitation, as Yuri pointed out. We initially did not have the agreement that an unlimited number of members could be added under our subscription fee. We initially had a limit based on the standard subscription fee, and so when that information was distributed as part of the invitation to join the network, it created some hesitation amongst people who were considering becoming members. Another challenge that we have discovered as the network administrators is that it's very challenging and time-consuming to reach out, in some cases over an hour to an hour and a half drive from where we are in Brazos County to some of the more remote parts of some of the surrounding counties, to be able to invite them and provide demonstrations to them for members. And then, of course, there's always the hurdle of something new, as Yuri also pointed out, that having that pre-talk about, is this something that everybody, the players, can get on board with and agrees is a need for our community, and is this the best way to go about doing this, would have been extremely useful. We did have one network group that was introduced to Charity Tracker early on. It was a group of faith-based organizations, but again, pastors are among some of the most busy people that we encounter in our community, and sometimes it's a little bit harder to offer this as a resource because I'm not exactly sure, but they may view it as a way of opening another door for service from their organization. We wanted to make it available, since it's members only, cloud-based, and secure, available as a resource communication and coordination piece pre-packed with resource information, so that when they got those calls, they would be able to respond to them. We have the capability to make referrals within the system to other members of the organization, and that's also another lesson learned, that in order to make referrals in the system, we can't do it to anybody who is just listed as a resource. They do have to be members of the system, and it is closed, and it is secure as part of the network. And it does have the data component as part of the network as well, to collect the information on what assistance was provided to a particular individual once they are entered into the system in the data component of the network. So our staff is pretty small. When we had 4 full-time people when we started, we're down to 2 at the moment, but we intend to complete our staffing so that we are up again to 4 people in our community network area here. And again, because my office manager is our Charity Tracker expert, we are able to offer demos either at our own organization or to go out in the community because it's cloud-based, to anybody with a computer that has is connected to the internet. And with that, I would like to turn over the presentation to Kristen Scholl so that she can continue the description of her experience.
Great. Thank you so much, Pat. And good afternoon, everyone. I'm here this afternoon with my colleague, Lori Peterson, and we've prepared this presentation to walk you through our social care referral program journey. So just a little bit about who is the Alliance for Better Health. So the Alliance for Better Health is a provider system created as a result of the New York State Delivery System Reform Incentive Payment Program. And I know that's a mouthful. We usually call it the DSRIP program. So New York State created this DSRIP program as part of the New York State Medicaid Redesign Initiative in New York State, and we're one of 25 systems in New York State that carries out the goals of DSRIP. Alliance is comprised of 3 hospital systems, 2 federally qualified health centers, and many primary care, behavioral health, and community-based organizations. The specific goals of New York State DSRIP are to decrease avoidable hospital use and preventable emergency department use by 25%, and that is specifically for the Medicaid population, since this is funded by the New York State Department of Health as it relates to the Medicaid population. So there are other measures of success in addition to avoidable hospital use. Measures of success include HEDIS and other avoidable hospital use measures. Some of those same measures that are used to measure success in a value-based payment contract environment. So DSRIP is a 5-year demonstration program that is wrapping up in 2020. So what's happening now, Alliance and the other DSRIP provider systems are in the process of assessing the programs that have been implemented under the DSRIP auspice and finding those that are effective and then determining really how to make those programs sustainable. So the Alliance has decided as our sustainability initiative to create an IPA, which is an independent practice association. Our IPA is called the Healthy Alliance IPA, and this is an organization that we have created to be a contracting agency for our community-based organizations, or as we call them here at the Alliance, our social care organizations. So the IPA will be able to then contract with managed care organizations and other types of entities to fund this program on the long term. So that's kind of our sustainability plan. So, and which is very important to our partner organizations who participate in our referral program, as we'll talk about later. So just quickly to tell you our mission, vision, and goals, because this very much aligns with our referral program journey. So the mission here at the Alliance is to transform care to improve the health of our communities, to create really a united and collaborative delivery community. So we want to break down silos. Our goal, one of our goals, is to support our partners in the move from volume to value. So again, to help our partners, all of our partners, to be successful in a value-based payment contracting environment. The opportunity that we see is to implement phased-in social care programs, really focusing on upstream care, and then expand upon those programs that have been shown to have a clear return on investment in a value-based payment environment. So one of these social care programs that we're talking about is, today our referral program that we use the UNITA infrastructure for. So let's talk a little bit about the opportunity. So why was the Alliance even looking for a social care referral platform? So in the earlier phases of DSRIP, our partners validated, I think what we already knew, was that in order to improve the clinical outcomes for our Medicaid community, we needed to address the social determinants of health. So this was very important to us. We became laser focused on this mission. And so the formal, more prescriptive DSRIP project came to an end last spring, and we adjusted our focus on like I said, the upstream social determinants of health. We knew people were falling through the cracks in the healthcare system, and we wanted to help bridge that gap. So implementation of a social care referral program is very much in line with the Alliance mission, vision, and goals. So we moved forward. So just to talk a little bit about the process that we use to decide on what referral program we would implement. We identified the problem. So you can see on your screen all the issues, but to highlight the problems that we were really focused on is there was no infrastructure to manage referrals in our community, and there was no accountability for referral outcomes. So clients were falling through the cracks, and there was really no mechanism for our community to be able to know, who was falling through the cracks or what those gaps were. So we saw the need for this type of program. The next step, once we decided that a referral program was something that could help us solve our problem, was we had a discussion about buy versus build, and we actually did, some discovery about building our own program, and we actually then decided on buying a program. We issued an RFP, we analyzed the results, and we actually even hosted an innovation summit, kind of a Shark Tank type experience. So after all of that, we reviewed our options and shared our analysis with the Alliance IT Committee and the Alliance Board, which is comprised of our community organization members, and we selected the Unite Us platform. We selected Unite Us because not only did the technology platform meet our needs, but also because the program and model around the Unite Us platform was very much aligned with our mission, vision, and goals. So one thing that I would say is if your organization is looking for a referral platform, I would encourage you to go through that whole problem-solving exercise and be sure that the solution you choose addresses the specific problem that you're trying to solve, and that the solution will meet your needs and be aligned with your own mission, vision, and goals. So why did we pick Unite Us? So Unite Us is a HIPAA-compliant platform. I think many others are. We like the fact that the Unite Us platform does give some special attention to some sensitive referral areas. There's special privacy as it relates to behavioral health, addiction, physical health referrals, and legal referrals. We like that this particular platform takes the onus from the client and really puts it in the hands of the social care organizations and clinical care organizations to help serve the client. We like that this particular platform is very easy to navigate and gives our providers insight into their client's social care journey. And that this is a tool for community-wide data collection so that we can then use this data in order to measure the success of our program. One other component that I wanted to highlight too is that the infrastructure here gives us the ability not only to refer to the in-network providers that have signed on to this platform, but it allows our coordination center a mechanism for accepting referrals to out-of-network providers so we can then bring those organizations into our network. Okay, so introducing Healthy Together. So after we selected the technology platform, now it was time to really develop the program. So the Unite Us model, just like the others, uses this closed-loop referral technology, but the piece that we like that I think is a little different is that it really combines this technology with a coordination center approach. And the coordination center is really the hub of facilitating referrals and being a resource for our provider organizations that need help and are not quite sure, who can best serve their clients. The coordination center also monitors referral activity and really creates that sense of accountability and gives us a sense of sustainability with this program. The ultimate goal is to be sure that clients are being connected to the services they need and folks are not falling through the cracks. So really importantly, and I know we heard this from Pat and we heard it from Yuri earlier, is that we needed to socialize and communicate the program broadly, and our community partners were very involved in the development of our program all the whole time from the beginning to the end, and they are now as we optimize and make the system even better and a better resource for our community members. So we introduced the Healthy Together program in April of 2018, just about a year ago. We watched it through the summer. We made some minor adjustments, and we really just were not seeing the adoption that we hoped for. We still, saw our providers and partners using their old referral methods for those social care referrals. And so we thought, how can we make the program more robust and make this a tool that our partners would want to use that would best serve their clients. So we went back out to our partner organizations and we asked them. So we had a voice of the customer exercise. And so now it was time to optimize. So starting in the fall of 2018, we really had a full-on effort to optimize our Healthy Together program. We grew the network. We collaborated with our neighboring PPS to the north. We embedded a Health Lead social determinant screening tool selected by the community, change management efforts. We sent our care coordinator, Kate Collins, out into the field to help our partners adopt their workflows, and we communicated broadly. We also introduced a circulation program, which is really a transportation platform to get our clients to their social care appointments, as this was identified as a need. So where did the optimization get us? So we now have over 200 organizations across 13 counties. We've served over 1,200 clients. We've made over 2,000 referrals in our area. The social determinant screening tool that we're using is the Health Leads tool. I'll walk really quickly through a use case. So this is a day in the life of Bob with no social interventions. Bob goes to the emergency room for pain and nausea. He has an expensive workup. He's discharged home with a prescription and diabetic info sheet. He goes home with no prescription. He can't afford his healthy food. He ends up back in the emergency room again. And so then what happens with Bob with social care interventions? Bob is seen by his primary care in his federally qualified health center. They administer a Health Lead screening tool, which is embedded in the Unitas platform. It's determined that he has a food insecurity. The primary care is savvy. They've coded this with the appropriate Z code in their EHR. They refer Bob to a local food pharmacy, making a referral in Healthy Together on that Unitas platform. They acknowledge his transportation barrier. They schedule a ride for him using circulation, and then they partner with a health coaching program called City HealthWorks, who sends a coach out to Bob's home and teaches him how to self-manage his diabetes. Bob no longer suffers from symptoms of diabetes. No more emergency room visits. That's the ideal state. And so just to talk about what is working here at the Alliance. So our close partnership with Unitas has really allowed us to integrate the referral platform into our much larger social care program. Customized training for each agency by our experienced care coordinator, again, our Kate Collins, our famous Kate Collins, is working great. What we knew wasn't working is generic navigation training, so we really needed that hands-on training. We regularly make program adjustments based on community feedback. The provider accountability that we get with the Unitas platform and having network standards, case conferences for high-volume agencies, no cost to the program providers, and then providing a clear understanding to our partners of the sustainability of the program, I think is what has shown to be working to date. So with that, I think I will hand it back to Yuri for our question and answers.
Great. So Caroline and I are going to go through a few questions, although we are a little bit pressed for time. Caroline?
Hi, everyone. First of all, Pat and Kirsten, thank you so much for those great presentations. We have gotten a lot of questions, and I want to let people know for the questions we don't get to, we will do a Q&A responsive to them and post those afterwards. It feels like there have been a few different questions about the report that I think we could get out of the way really quickly. So one was around whether we're planning to evaluate additional platforms. We are not currently.
we realize there's a lot coming in. We do have a list in one of the appendices of the report of other platforms that we came across that we didn't have the opportunity to include in this review. We do agree that there's a need for some kind of ongoing effort to keep kind of monitoring these, and if that's something that we have the time and resources to do, we would do, but we don't currently plan to do that. There was a question about cost. So there is information about cost of these platforms in the report. So there's both information kind of going across, giving a ballpark about that, and then for each of the platforms, as much of the information that we could get about cost is in the report. So I would definitely go and look about that. And then I think in terms of other questions, there were a number of questions that came in around evaluation that I wanted to just kind of quickly mention a few thoughts around evaluation metrics. Definitely patient and provider and partner satisfaction, I would imagine, would be the first thing that you would want to be measuring. And you can do that both informally or do surveys, et cetera. I think the next one is really around social needs resolution. And that's really what the closed-loop referral is meant to help you do. As we mentioned, that tends to be one of the major sticking points of implementing these platforms, so it's not necessarily an easy thing to do, but that's one of the key things. And then the other thing is the health impacts, and then efficiency. I think efficiency is the other piece that's really important for people to be thinking about. The whole point of implementing these platforms is making this process more efficient. And so figuring out ways to figure out, is this actually more efficient for your staff? Is this actually more efficient for getting the information and for getting referrals out, et cetera, I think is important. So we have a whole bunch of different questions. One that came in, I think that hasn't been answered would be, how do you help the network participants to implement these tools? And how, speaking of evaluation, how are you gathering information about client satisfaction, both from patients and network participants? I don't know if either of you want to go ahead and share what you did.
Hi, this is Kristen from the Alliance. So one of the ways that we've really helped people to adopt the use of the platform is we work really closely with the Unite Us customer success team with regular trainings. At Alliance here, we have a team of community engagement folks who are meeting with our partner organizations regularly to help, adopt the use of the Unite Us tool. We have regular community forums where we talk about best practice, and we help people, again, to integrate into their workflow. Also, we use the Unite Us dashboards to provide full transparency into like a referral leaderboard, what types of referrals are being made, the types of referrals that are being made, and outcomes of the referrals that are being made. And it just helps our entire network to be more savvy and to really understand how the work is all interconnected.
Thank you. Here's another question about closed loop. One person asked if there are closed loop referral models that put the onus on the client versus the community organization. And Yuri, I wonder if you want to take a stab at that.
Yes, so there are a couple of these platforms, and probably, these, as new features are being pushed out all the time, I don't really want to venture to answer which ones because it's likely to change, but a few send text messages to the patients to follow up to see if they've gone to the resources that they've been referred to. And several offer patient-facing interfaces where the patient can log in and kind of similarly to the patient portal of an EHR can see their pending referrals and can say, yes, I went, or no, I decided not to go, et cetera. So that is available as a functionality. However, we heard that patients are really not taking this up uniformly. And so there's some interesting questions there about what can be done to increase patient engagement on that front.
Great. And I want to ask Pat and Kristen and Lori this other question I think that's coming in from a number of people, which is about being able to track outcomes, potentially both, I think, social needs, resolution of social needs, and then potentially other outcomes like health outcomes. Are you able to do that in your particular situations? And if not, why not?
This is Lori. Thank you. We actually utilize, Kristen mentioned the dashboards on the back end of the Unitas platform. We're able to extract the data, and using some additional data sources, we're able to understand how the referral and the social care intervention had impacted the health outcomes of that individual, either because of a reduction, for example, in their emergency room usage, which we saw in our use case, or because they actually had improved health as measured by their amount of overall touch points with a traditional medical healthcare system.
For Charity Tracker, there is an outcomes, there is a goal setting portion that's geared toward social service, goal setting that is very customizable, and the reporting is very customizable as well. We are tracking those people that we are interacting with in terms of what the results and the outcomes are. And some of the things that we are doing have only been implemented in about the last 6 or 8 months. And we're starting to see a turn in the tide of high users for the hospital for both ER and inpatient stays. And there are reductions once we get them connected and are meeting some of these needs using either community resources or some of the resources that are actually being supplied directly by the hospital itself. Seeing that in Texas we don't have an expansion of Medicaid. So there is also a district program in place here that's kind of a partner organization with us. And so we're using Charity Tracker to try to both expand the number of people who have access to the information in terms of our network partners, but also to track all those cases that we are directly interacting in since they have that data component.
And Pat,
thank you.
I'm sorry.
I think we're at time.
Oh, sorry, thank you.
So we're going to have to end here. Thank you so much for all of you who have logged in. Again, the slides are going to be put online, the webinar is recorded, and we're going to do our best to answer all the questions that we didn't get to answer. I will say that a lot of them also you will find answers in the report. So please do go look at the report. There are answers about cost, there are answers about the functionalities of the different platforms, and a lot of the questions that were coming in. Please let us know your thoughts about this webinar by filling out the survey that it pops up once you log out of the webinar platform. Thank you so much to our speakers. Thanks to all of you. Thanks to Xiaoqi and our funders, and I hope you all have a good rest of your day.